Hi, I'm Dr. Alex Kabiri, and thank you for allowing me to talk to you for a few minutes about amniotic membrane therapy. A couple of things that have to do with what we see when we look at the front of the eye. What we're seeing on the front of the eye more often than not is a snapshot in time of more than one disease entity active on the front of the eye. Commonly, dry eye is one of them. Allergy could be another one. But then there are a lot of other things happening as well. Sometimes there's a bit of reduced corneal sensitivity, which suggests there's a neurotrophic component to what's happening on the front of the eye as well. Sometimes when you see staining on the front of the eye, if you increase the magnification, you might notice that some of these areas that stain actually are little microfilaments forming, so they have a very early or mild filamentary keratitis component as well as other forms of keratitis that could be, let's say, exposure keratoconjunctivitis in someone who's an incomplete blinker or who has a bit of lag ophthalmos, in the nighttime. So there are all these things that are active on the front of the eye. And then the low-hanging fruit that's easy to call out is, oh, you have a breakup. Oh, you have a quick tear breakup time with corneal staining, so you have dryness of the front of the eye. And that's true. They do have ocular surface dryness, but they have other stuff happening as well. So how do you tease some of this stuff apart? First of all, just to put it out there, if we're being very strict, amniotic membrane therapy is not really indicated for your run-of-the-mill dry eye. It's super helpful, but it's not indicated on label for it. Why is it super helpful then and not indicated for it? Because, as we just said, there are oftentimes multiple disease states running across the front of the eye, many of which amniotic membrane is really helpful for. And once those things are out of the way, the dry eye starts to get better. So how do we tease some of it apart? Well, if you're not used to thinking like this, when you start treating somebody for dry eye, or you start treating the dry eye component that's obvious and evident to you, when they come back for follow-up, if you're not seeing the right kind of improvement or similar improvement to what you see in other patients with equally appropriate treatment, then it's time to start thinking there may be some other processes active on the front of the eye and start to tease them apart. Whether it's filamentary keratitis, whether there's a neurotrophic component, an exposure component, what have you, whether somebody has a little bit of epithelial basement membrane dystrophy, there might be a small nodule on the cornea, things like that. These are all things that amniotic membrane can be helpful with, as well as limbal stem cell deficiency. That's another one that if you're not familiar with it, take a look at it and see what it is and what it looks like, and then you might start to recall patients that had some of these similar appearances, presentations, and histories. So for all of these other things, amniotic membrane can be really helpful. Also, when selecting a graft to use, my personal favorite go-to right now is a graft made by Ophthalogix called Aurora that is a dehydrated product, but it does have a central aperture that allows the patient to have no visual disruption when the graft is placed. It also spares the central cornea, and why that's important is for a few reasons. One, if you treat both eyes at the same time, which we usually don't, but if you do, you don't want the patient to leave super blurry in both eyes, so it's nice to have that pupil sparing in both eyes. If you have a functionally monocular patient, and that's the eye that you're treating, it's nice for them to leave with no visual disruption due to the placement of the graft, and again, that central aperture allows for that. And lastly, when you think of things that can complications that can spill out of amniotic membrane therapy, the one you really want to be on the lookout for is hypoxic keratitis and all the sequelae that could go along with it. Ultimately, worst case being a hypoxic ulcer, which if it's within that central pupillary zone, is not only very long-term disruptive to the patient, but could leave them with a provable loss that could become a long-term disruption and problem for the provider. If we're not covering the central cornea, the risk of central hypoxia within that pupillary zone goes way down. So now we have a product that's safer for patient and provider when it comes to essentially taking off the table what would be the worst complication of this sort of treatment. So again, Aurora has become my favorite go-to product. I use it, if it's not every day, it's close to it. That's pretty much it. So thank you so much for allowing me the time, and I hope you have a good experience, you and your patients, with amniotic membrane treatment. Thank you.